Should I just start?
Yeah, I was just about to introduce you. You can start sharing your slide for now. Yeah, it's 11:56, so we might as well get started. So just an overview in terms of the rules for this breakout room. Each presentation will be 3 minutes in length, and I will be timing you. If you're getting close to the end around the 3-minute mark, I won't interrupt you. Otherwise, I'll just let you know that your time's up. And then we'll do 4 presentations first, and then take 5-10 minutes for questions. And then we'll do the other 3 presentations at the end, and then questions again for the remaining presentations. And there will be, or there was a link, or if not, it will be posted soon to evaluate the presentations. So it's my pleasure to introduce our first speaker, Samuel Lamanuzzi. Sorry if I mispronounced it. His presentation is on markerless motion capture systems in pediatric sports medicine, a scoping review.
Okay, thank you. So yeah, my name is Samuel Lamanuzzi, and today I'll be presenting a scoping review on markerless motion capture systems in pediatric sports medicine. So to address the high prevalence of sports-related injuries among the youth, prevention programs which assess biomechanical risk factors are necessary. Currently, most motion analysis laboratories collect biomechanical data through marker-based motion capture systems. However, marker-based motion capture possesses several limitations, such as the variability of marker-skin interactions, the cost, the time required for marker placement, and the inaccessibility of outside laboratory use. Current markerless systems, which assess movement without reflective markers, aim to rectify these limitations. Ultimately, this scoping review aimed to identify research gaps that needed to be filled to better understand the capacities of markerless systems in screening and evaluating youth in the field of sports medicine rehab, performance, and injury prevention. A scoping review was conducted on the existing literature from June 2008 to July 2001 using the PRISMA SCR checklist on 3 databases, Medline, Scopus, and Sportdiscus. Data extraction was developed to synthesize results on general study characteristics, type of markerless motion capture system, strength and weaknesses of the markerless systems, post-processing method, and primary outcomes. Of the 734 articles which were screened for eligibility, 65 articles were included in this review. A total of 34 different markerless motion capture systems evaluated biomechanical data, so either kinematic or kinetic. As you can see, we found 4 validation articles, 18 that assessed rehab or injury prevention, 34 for performance, 12 for both the lower and upper extremities, and then 24 that assessed full body or various other locations. So markerless motion capture is becoming an increasingly important tool when assessing biomechanical properties outside of the laboratory. It is essential when collecting and analyzing high volumes of data quickly and within field. The scoping review identified several knowledge gaps within the existing literature, the main ones being the lack of standardization of marker placement, so the number and location, and the type of markerless motion capture system employed. The variability of these parameters makes it difficult to determine the reliability of these technologies, along with the fact that only 4 validation studies were identified. Also, most of the selected studies evaluated older young adults, suggesting a lack of assessment for a younger pediatric population. In sum, markerless motion capture systems are a promising technology in the field of sports medicine for out-of-laboratory use in certain circumstances, but more research is required to assess their validity and reliability.
Thank you. That was right on time. Good job. Our next presentation is by Sirion. Oh gosh, Oxorn. I'm so sorry for butchering your last name.
Okay. That's fine. So I hope you see my presentation.
Yeah, we do.
Okay.
So she'll be presenting on collagen degradation markers in mouse models of osteogenesis imperfecta, systematic review and meta-analysis. So go ahead.
Okay, so hello everyone. Today I'd like to present my work about collagen degradation marker in mouse model of osteogenesis imperfecta, or OI, which is a genetic disease caused by collagen mutation leading to bone fragility. Collagen is secreted by osteoblasts during bone formation. However, another cell types in bone, osteoclasts, are also affected, as reported by increased the number and size. And recently, bisphosphonate, osteoclast targeting drug, also used as a standard treatment for OI. So we hypothesize that osteoclasts might play an important role in pathogenesis of OI. And nowadays, various animal models of OI were developed that give a different degree of bone severity. Leading to the objective of my study, I'd like to understand how osteoclasts are affected in this disease. And in this talk, I will focus on osteoclast function in different mouse models of OI from the previous study and summarize the data by using meta-analysis. So I developed the search strategy by using medical term of OI together with osteoclast-related parameter, and only the study that report collagen degradation markers such as the CTX1, DPD were recruited to the analysis because these markers represent bone resorption by osteoclasts. And here is the result of my study. I identified 8 animal studies describing 5 models of OI mice, for example, the BRTL, the OIM mice. So individual study will compute effect size using the standardized mean difference between the level in OI compared to the healthy wild type mice. So we can compute the overall effect, which is 2.05, that indicates significant increase in collagen degradation marker in OI mice. And we also study the bone severity from different strain of OI mice by considering the frequency of fracture, bone deformity, histopathology, effect on the bone mass and the body size. So we able to compute the severity score as presented in this table. Interestingly, the linear regression also showed the positive correlation between the severity score with the increase in collagen degradation markers from 5 models of OI mice. So not just only osteoblasts, but osteoclasts also have higher level of collagen degradation marker, representing higher osteoclast activity, especially in the severe OI. So I would like to thank all the Komaloa Labs member, and thank you so much for your attention.
Thank you. And again, right on time. And we'll just move on to the next presentation by Shrita Jain. She's here. Awesome. So Shrita will be presenting about the prescription and consumption of opioids after bariatric surgery, protocol for a multi-center prospective cohort study. Go ahead.
Can everyone see that?
Yes.
Okay, great. Hi, everyone. My name is Shrita. My supervisor is Dr. Julia Fiore, and our work is primarily focused on surgical outcomes. Have you or someone in your family ever had a procedure done where you've been left with an excessive amount of pain medication and not known what to do with it? The overprescription of opioids by surgeons, mainly for pain management, has unfortunately become a significant contributor to the devastating opioid crisis. In addition to the risk of patients using and misusing opioids, surprisingly, up to 70% of the prescribed pills may go unused, which, if not stored or disposed of properly, can be diverted for non-medicinal use within the community. Bariatric patients or weight loss surgery patients particularly may be at high risk of misusing opioids. This may be due to impulse control deficits morbidly obese patients commonly face, the fact that they may already be consuming opioids for chronic pain they're having, or even the anatomical changes promoted by bariatric surgery that affects the rate of absorption of opioids within these patients. In fact, in a study of a surgical population who have never consumed opioids before, bariatric patients had the second highest incidence of persistent opioid use postoperatively. Therefore, optimizing these prescriptions can be an important target for quality of care improvement. However, there is a lack of research addressing opioid prescribing and consumption patterns specifically for bariatric surgery. Therefore, we hypothesized that current opioid prescribing practices poorly reflect the actual needs of patients undergoing bariatric surgery. So we planned a multi-center prospective cohort study where we recruited adult patients from 3 centers undergoing bariatric surgery. We had a target sample size of 350 patients, and we began recruitment at the end of last September. We just finished recruitment this April and are in the process of completing patient follow-ups. Including medical chart review, we're also collecting patient-reported data where we're administering questionnaires either online or by phone. The assessments are described here, where preoperatively, as a baseline measure, we're asking questions regarding their health and their history with pain and how they deal with it and any previous use of opioids. Postoperatively, we're following up with them once a week for 4 weeks after discharge from the hospital with questions regarding health, their use of opioids and any related side effects, and any postoperative complications they may have had. The rate of postoperative opioid prescribing and consumption will be analyzed descriptively, and linear regression will be used to assess any patient and procedure characteristics that may predict postoperative consumption, such as age, gender, pain catastrophizing, type of surgery, preoperative pain, etc. Given the high rates of prolonged opioid use after bariatric surgery, with this study, we hope to better understand the difference between how much pain medications these patients actually need versus how much is being prescribed. This could hopefully inform future studies on how to reduce opioid overprescription and the consequential harms to these patients after bariatric surgery. Thank you.
Awesome. Thanks, Shrita. And we'll just move on to our next presentation again, and then we'll do a break after for questions. It is Syed Azhar who will be presenting on the comparison of 2 virtual simulation technologies in medical education, an assessment of cognitive load, usability, and performance differences.
Thank you. Hi, everyone. Welcome to my talk on the comparison of 2 virtual simulation technologies in medical education, where we looked at cognitive load, usability, and performance differences. To contextualize my presentation, I want to draw attention towards some of the challenges that healthcare learners face during their training. These include non-optimal training environments and reduced work hours, which lead to less time to practice medicine. To combat this, virtual simulation can be used. Virtual simulation technology includes both headset-based virtual reality and screen-based virtual simulations. In headset virtual reality, healthcare learners can enter a totally immersive 3-dimensional experience anywhere in the world using a VR headset. Screen-based virtual simulation, on the other hand, use a monitor screen to replicate the same experience at the cost of true immersion. So the question then becomes, which modality is the best for learning? There are many factors to consider when answering this question, and the key factors that we chose to look at were usability, cognitive load, and performance scores. To answer our research question, we recruited medical students from McGill University, and upon arrival to our lab space, they were randomized to complete either a headset VR scenario or a screen-based scenario. All participants filled out a pre-simulation survey as well as a post-simulation survey. And at the end of the scenarios, they also obtained a software-generated simulation performance score. In order to address our interest regarding usability, we utilize the system usability scale. To look at cognitive load differences between the modalities, we use Leping's cognitive load scale. And to see performance differences, we use simulation performance scores. We found that between headset and screen-based VS, medical students did not report any significant differences in usability. Next, in terms of cognitive load types, we found that all types did not be statistically significantly different. However, there was a large mean difference that was approaching statistical significance with a p-value of 0.06 in germane cognitive load specifically. Lastly, in terms of students' performance scores, there was no significant difference between the modalities. So our preliminary results suggest that screen-based VS and headset-based VR modalities might be similar in terms of the cognitive load required to operate them. In terms of students' ratings of their usability, our current data shows that one modality does not outperform the other, and the lack of significant performance score differences between the 2 modalities suggests that simulation educators may have more flexibility in choosing one technology over the other without significantly impacting student learning. Taken together, this indicates that both modalities might offer similar value to students. However, it's important to note that our current analysis was limited due to our small sample size, and these results should be interpreted with caution. The findings presented here are preliminary, and future ongoing additions to our dataset is going to yield more comprehensive results. Ultimately, our work here will help contribute a rare insight into the use of these virtual simulation technologies in healthcare education. Thank you all for listening, and I appreciate your time.
Thank you. So now we'll move on to about 5 minutes of questions. Does anyone have questions for our first 4 presenters? If so, you can raise your hand or feel free to just start talking. Oh, Dr. Fiore, go ahead.
I say I had great presentation. I just have a quick question about your assessment of cognitive load. Like, is it like, I wonder if you could like explain that a little bit better. Is it a questionnaire that it's, you ask like participants to respond, and exactly like what the questions entail?
Yep, absolutely. That's a wonderful question. Thank you for asking that. Specifically, we used a cognitive load scale that has been validated in the past, and it's also shown to be a reliable cognitive load scale. It's called the LEPIX Cognitive Load Scale. I believe it has 10 questions, and those 10 questions are broken up into 3 different factors, which measure 3 different cognitive load types. The first one is intrinsic cognitive load, and here we're just talking about essential processing, where it's the inherent demands of learning the material. So having background knowledge might help someone reduce one's intrinsic cognitive load. The other thing it measures, the second factor, is extrinsic cognitive load, and this is sort of the cognitive load that's related to the presentation of the material. So this can stem from like poor instructional design, such as a picture and its description appearing on different pages and requiring like scanning back and forth for the reader. Then the last thing it measures is germane cognitive load. So while intrinsic and essential cognitive processing is impacted by the complexity of the material, this type, germane, sort of impacted by one's own motivation to learn and the subsequent efforts and strategies one will use to organize and sort of integrate that information in their minds. Does that answer your question?
It definitely does. You responded so well that it even seems that we rehearsed the question and answer. Well done. Cheers.
Thank you.
Thanks, Maxine. Go ahead.
Hi, this is a question for Shrita. First of all, great presentation. This is regarding your preoperative measures. So you mentioned using things like PROMIS 29 and PAM. Can you describe what they are and why they might be useful measures to predict your outcome of interest?
Yeah, for sure. Thank you for your question, Max. So our preoperative measures are mainly focused on like patient-reported outcomes. So what we find is that some components of recovery, like length of stay, et cetera, are not considered that important for patients. And rather, it's important to consider aspects of like how they are recovering fully to their optimal like quality of life. So to assess that, we're asking questions like, and we're giving a questionnaire such as like the PROMIS 29, which is the full form is like patient-reported outcomes in measurement information system, and it has like 29 questions assessing health-related quality of life with 7 domains. With domains such as anxiety, depression, fatigue, sleep disturbances, physical function, etc. So like aspects that would be really important for patients after the recovery from surgery. Apart from that, we also have a few characteristics about pain that we think that could be important predictors for postoperative consumption, such as chronic pain they may have had before surgery, PAM, as you mentioned, the pain activation measure. There are questions regarding their engagement in healthcare and how knowledgeable and confident they feel about their healthcare, which is an important aspect about how they recover and how they feel about their recovery. And pain catastrophizing, which is like how of individual, like their tendency to catastrophize their feelings of pain, which could also change their responses of how they're feeling about pain after surgery. So yeah, I hope that answers your question. Thanks.
Yeah, definitely. Thank you.
Dr. Harley?
I had a very general question for Shrita. So you mentioned that, again, and part of the rationale for all the important work that you and Julia were doing with opioids is that it's not only addictive, but in some cases, it's also people not using their opioids, having it being overprescribed, in some cases, what sound like really epic proportions. It's getting back, unfortunately, to I guess it's somehow it's getting back to people who are then continuing to use it to, as part of their addiction. I wondered, and I know this isn't exactly what you're studying, but whether you could talk maybe a little bit more about kind of how that trickle down effect works and what kind of, whether there's any concerns or how might you deal with, my guess would be that entirely relying on Breaking Bad as my point of reference for drug trafficking, that people might be reticent to talk about selling their opioids or something, or unless people are going dumpster diving for opioids. I just wondered if you could talk a little bit about how about kind of that side of things, and whether there's any concerns about that subset of opioid using patients being there being a concern about them reporting honestly.
Of course, that's a really great question. So actually, one of our secondary research questions for our entire protocol is to see how patients are storing or disposing the medication that they have left at 4 weeks after discharge. So like generally after 4 weeks, we assume that they will stop using opioid stuff. So we ask them like how they're storing it, and if they've stored it, or if they disposed it, how they dispose it. We have like a multiple choice option where they're like, did you return it back to the pharmacy? Is it in your cabinet? Did you throw it in the trash, etc.? And so hopefully unfortunately, we won't know what happens after they dispose of it or after they store it, but at least we can have an idea on how patients deal with the pain medication they have left, if they do any, and that could give us a little insight on what we can do in terms of like patient education on like what to do with these leftover medications, etc. Does that help?
Yeah, no, that's great. I suspect that there's probably definitely work that could be done with patient education. For example, if they're able to return the medication to the pharmacist, and the pharmacist would be, able to do something with the pills, whether that's even just, put them in the fireplace or something like that. Not that the pharmacy likely has a fireplace, but you know what I mean? That would likely be interesting to know too, just in terms of what the patients understand their options are, and maybe the risks are of putting it in the garbage or recycling bin or something like that. Thanks so much. Great answer.
Do you have any other questions? We have a couple minutes that we could spend. If not, I have a very simple-ish question for Shrita as well. I think it was your methodology section for your 30-day complications where you wrote CCI index. I'm wondering if you could elaborate, because what I thought the CCI was for comorbidities. I'm wondering if you could comment on what you used for the complications at 30 days.
Yeah, so the CCI kind of, it's like a 5-grade complication index, and it basically grades your type of postoperative complication into the severity of treatment of you get for the complication. For example, if after your surgery you need an endoscopy after your surgery for some type of internal bleeding, then it's going to be like a grade 2 complication. We're going to need a surgical kind of intervention. A grade 1 complication is something where you don't need any kind of pharmacotherapy or any kind of complication. You just had a complication and you just take simple medications like diuretics or something for it. So according to that, we grade our complications and we give that as a quantitative number to it. But
that's like Clavian Dindo score, right? Or 5 was like death, that one?
Yes.
Yeah. Okay.
Yeah. So it's like a modified version of it, but yeah.
Okay. Thank you. If we don't have any other questions, we could proceed on to the next 3 presentations.
Can I just make a comment, Anita?
Yeah, of course.
So one thing that is very confusing in the surgical literature is that we have 2 CCIs. We have a CCI, which is the Charleston comorbidity index, which is probably something that you have in mind. And the other one is the comprehensive complication index, which is what we are assessing. So
thank you.
They are quite different, but the acronym is the same. That's what makes it a bit confusing.
Yeah, thank you so much. Okay, so our next presenter is Matthew Moreno. Matthew, you can go ahead and share your slide. He'll be presenting on the leadership and group emotional regulation dynamics in medical residence.
Can everyone see this?
Yes.
Everyone can hear me?
Yes.
Fantastic. Hi, everyone. My name is Matthew Moreno. My name is Matthew Moreno. I'm a postdoc in Dr. Jason Harley's lab, and I'm presenting leadership and group emotion regulation dynamics in medical residence. We know that leadership in medical settings has an impact on the effectiveness of medical education simulations and an effect on the development of group regulation skills in residents, and which in turn has an effect on their ability to be delivering the most effective and appropriate patient care. Our research questions for this ongoing project were to examine the behaviors observed in group leadership and group emotion regulation, to understand the role of leadership in collaborative medical simulation environments. In this study, we used a case study methodology within a constructivist grounded theory, and we used inductive and deductive coding of behaviors, including a coding scheme that we developed for this project, which combined achievement emotion codes, behavioral observations, as well as individual and group level emotion regulation strategies, all in one single coding books, so that we could understand a little bit more about our participants. Our participants were second-year medical residents, internal medicine students, who were put into two equal groups of 4. They were given a crisis resource management simulation training scenario where there was an appointed leader and 3 residents in supporting roles. Crisis resource management principles were expected to be employed, and the scenario lasted approximately 10 minutes, where the patient showed clinical deterioration to evaluate the residents' reasoning and decision-making abilities. Following this, debriefings happened at the end of every scenario. Our preliminary results indicate that leadership style influences group regulation dynamics. Democratic leadership styles tend to more likely use pro-social language and encourage group members to provide information that will be proactive in the group addressing issues, where autocratic leadership tends to use less pro-social language and emotion regulation strategies that actually discourage participation and group cohesion, which in turn, as we saw, this had an impact of leadership on performance and patient outcomes. In concluding, we see that leadership styles may have a role in the effectiveness of group regulation strategies. The emergence of interpersonal dynamics and teamwork have a role in the success of medical residents. And the CanMEDS framework, which focuses on development of leaders in medical educators, is an important integrated skill that is truly required in this role and should be encouraged. Thank you very much, everyone.
Thank you. And we'll just move on to our next presentation by Kira Greywall, who's presenting on how do residents manage emotions in challenging simulated team situations.
Thank you for that introduction. So to get started, hello everyone, my name is Kira, and today I'll be sharing how residents manage their emotions in challenging team situations. So to give a bit of background, emotions can be defined according to their valence, which refers to the level of pleasantness of an emotion, ranging from positive to negative. Also, emotions can affect performance, either enhancing or impairing it. Surgical residents train in team-based simulations where they need to work together to address a medical crisis. It's important that they regulate their own and their group members' emotions so that they can achieve optimal performance. According to the literature, there are 4 relevant emotion regulation strategies, with cognitive change being the most effective. Therefore, it's important to determine the emotion regulation strategies residents use, how effectively these strategies regulate emotions, and how they affect performance. The research questions we set out to answer are: which emotion regulation strategies are reported as most effective by medical trainees, and which are associated with self-reported performance satisfaction? To collect data, we developed a self-report tool, the Simulation Emotion Regulation Questionnaire, or the SMERQ. It identifies participants' emotional state, individual and group emotion regulation strategies used, and the perceived effectiveness of these strategies during a challenging event during the simulation. The study recruited 47 residents who were already enrolled in team-based medical training simulations. Team sizes ranged from 4 to 8 members. The SMERQ was administered before and after each simulation. Moving on to the results. Most participants reported feeling a negatively valenced emotion during a challenging event in the simulation. This graph illustrates how effectively participants rated the individual emotion regulation strategy they employed. Situation modification was rated as being significantly more effective at regulating emotions than attention deployment, which were the 2 most predominant strategies. This graph plots how participants perceived their individual performance against the individual emotion regulation strategy employed. As can be seen, perceived individual performance showed little variance. This graph illustrates the reported effectiveness of the group emotion regulation strategy employed. The other category represents strategies that we do not consider to regulate emotions and was significantly less effective at regulating emotions than the other emotion regulation strategies. Situation modification was the predominantly reported strategy, and no reports of group response modulation were made. This graph plots perceived individual performance against the group emotion regulation strategy employed. Again, there was little variance in how individuals perceived their performance. In conclusion, the frequency at which an emotion regulation strategy is used in team-based medical crisis simulations varies according to whether it is at the individual or group level. However, situation modification and attention deployment strategies are predominantly used at both the individual and group level. As the literature indicates that cognitive change is considered the most effective emotion regulation strategy, these results suggest that residents may be underutilizing potentially more effective strategies. Thank you for listening to my presentation.
Thank you so much. And for our final presentation, we'll move on to Ivan Yanev, who's presenting on the health economics of metastatic hormone-sensitive and non-metastatic castration-resistant prostate cancer, a systematic literature review. Do we have Ivan here? I do not see him. Does anyone know where he might be? If not, we can move on to questions while I try to figure out where our last presenter is. Does anyone have any questions for the first two talks we just saw? If not, Matthew, I guess I could ask you one question. I was just wondering how you chose internal medicine residents out of all of the other options that exist as your cohort.
Actually, there's Anita, there's there's actually a two-part to this. Number one is we want to kind of study a crisis resource management scenario specifically, and that just happened to be that we were able to find a partner that was actually conducting CRM sessions, and that just happened to be fantastic. Like it was a perfect partnership. Second, that's actually that's probably the kind of biggest decision on that. We needed that, and they turned out to be perfect, and the data was amazing. And we're, as I said, this is an ongoing project, so we're continuing to learn a little bit more, dissect, and do more layers of coding. So we'll hopefully come up with more conclusive and deeper analysis as this goes on.
Another dimension of this was, I guess we have to be honest, convenience as well. This was the first group of residents that we collected data for, and so we've had them a little bit longer than some of the other groups. I think we're up to over 75 residents in simulations or so now with this, but this was part of the first cohort and a group that also consented to their video data being used. So it's a really, as Matt said, CRM was a really interesting and relevant team-based scenario. So we're not looking at individual simulations, which restricts our sample or our population a little bit. But this was a good one, but more work to come.
Thank you so much. That makes sense. It's great study. Regarding our last speaker, apparently we have a recording for this person. In the moment, we'll just go on with questions if anyone else has more while I figure out where this recording is.
I have a quick question for Kira. Kira, I'm sorry if my question is too naive, but it's coming from someone who doesn't have experience at all in your field of research. But is it possible to realistically simulate stressful healthcare situations in a lab, in a simulation settings, or more specifically, can trainees be as stressed in a simulation environment compared to real life, or that's not even the goal of the simulation settings for your type of research?
That's a fantastic question, and actually it is something that that affects our research as well. So it really depends on the resident. This is the simulations that they take part of are already part of their training. It's meant to do just that, replicate the stressful environment, help them realize okay, I'm in this environment, I need to go through these algorithms and figure out what's wrong, really create a realistic environment. But because they are simulations, they use high fidelity mannequins, they there's still some residents who see that it's not as realistic. So sometimes they'll break character, they'll start laughing. Sometimes they will stop talking to the patient because they don't view it as an actual human. So there are some limitations with that simulation environment, but it is part of their training. And the purpose is to replicate that environment, even if residents may not view it as such. However, there are residents as well who get completely immersed within the environment. They find it super realistic.
It's a good question, Julia. I'll just expand while the video is being searched for. One of the main dimensions that's going to elicit, or that's going to account for eliciting a stronger emotional reaction, is residents' appraisals of value of a task. And as Kirat mentioned, because of the fact that this is something that these are important skills for them to develop for their training, for their future practice, this is going to help, elicit an emotional response, even if they're not immersed in the simulation itself. Even if, for example, the simulation patient isn't pulling them in, for example, what they're doing is still has consequence, and still reflects competence. So there still are going to be emotions. As Kirat mentioned too, there's a lot of individual variation in terms of how people are going to view the simulation itself. But aside from the immersion and the authenticity of the simulation, knowing that simulation is something is containing tasks and competencies that they need to master, helps assure a good level of emotional intensity for this sort of research. A lot of the work that's been done for emotion regulation, both in experimental psychology and in educational psychology, is in contrived situations, meaning they have very low or no ecological validity. So it's showing people pictures that are to elicit an emotion. It's not tied to anything that's personally or professionally important to the participant. So that's why what makes, to be honest, these really valuable and wonderful environments, for the studying and better understanding of emotion regulation, because we have a good baseline level of emotions. And as Kirat is probably, and other members of my team have seen, sometimes you don't need a physiological sensor to see the sweat on people's back. So sometimes it's definitely there quite a bit. It varies. Good question.
That's amazing. Thanks so much, guys.
Thanks, everyone. Awesome. So we will be playing Ivan's presentation right now. I just got a response from our VB Solution team. And also, I just want to thank everyone for staying under 3 minutes. That was impressive. Good job.
Anita, can you just tell me the title of your presentation, please?
Sure, it is the health economics of metastatic hormone-sensitive and non-metastatic castration-resistant prostate cancer, a systematic literature review.
Okay, I got it. It's
Thank you so
coming
much.
in right now.
My name is Ivan Yanev, and today I'm going to present you my project entitled The Health Economics of Advanced Prostate Cancer. We are going to focus on the metastatic hormone-sensitive prostate cancer and non-metastatic castration-resistant prostate cancer health states that are preceding the terminal stage of the disease. And the aim of this project is to review the scientific literature identifying economic evaluations of the latest treatments available for these two health states. We searched Medline, Embase, EBSCO, and the GRADE literature on June 29, 2021. Our PICO statement was focusing on the advanced prostate cancer health states, MHSPC and NMCRPC, selecting health economic evaluations of Health Canada approved medications. Our data extraction was done through an adaptation of the Winan et al. Formulary. Our bias assessment was conducted using the check extended checklist, and our transferability analysis was done through the Welt and al. Decision chart. This is our Prisma diagram. We started by a little bit over 1,000 studies that were selected through our database search and just under 300 studies from the gray literature. These records were screened and reviewed independently by 2 separate reviewers, and we ended up by selecting 23 studies and 19 health technology assessment reports. To our knowledge, this is the first systematic literature review that analyzes MHSPC and NMCRPC while integrating academic studies and governmental assessments. In the MHSPC setting, we identified that docetaxel plus ADT as the cost-effective and associated treatment to lower overall cost. However, the emergence of generic abiraterone acetate might come in contradiction to this conclusion. In the NMCRPC setting, enzalutamide, apalutamide, and darolutamide combined to ADT are considered cost-effective when compared to ADT alone. However, these studies are based on clinical trials that are presenting similar efficacy, and medication costs are on par. Now, looking at our limitations, we did not conduct any meta-analysis because of the great heterogeneity of the selected studies. Additionally, all the cost-effectiveness studies are based on results from randomized controlled trials and not real-world evidence. We additionally incorporated a certain degree of bias by including the gray literature and also by converting the results to 2021 Canadian dollars. We conclude that in the MHSPC setting, docetaxel plus ADT seems to be the cost-effective treatment unless major price reduction is made for abiraterone acetate. In the NMCRPC setting, we conclude that there were very few cost-effectiveness studies available to review. And our general conclusions are that there is an important unmet need for health economic evaluation assessing the novel treatments targeting MHSPC and NMCRPC in the Canadian setting. On this, I would like to thank you for your attention.
Thank you, Nico, for playing that. Does anyone have, I guess not questions, but we could discuss that talk if you would like, or leave the floor open for a couple minutes of questions for all 7 that we've seen so far, if anyone has any other questions or comments. And also just a reminder to complete the evaluation forms that were sent in the chat for this room. If not, you guys can get a break before our next chat or next session. What are your thoughts, team?
Great work, everyone. Thanks for sharing, Anita.
And yeah, the link was posted again in the chat here. Since we don't have any other questions, I'll just so yeah, thank you everyone for fantastic talks, and I'll see you guys in the other general room whenever they start again. I think we have about a 10-minute break if you want to go grab some coffee, food, anything you'd like, and have a great day.
Thanks so much, Anita. Great job.
Thanks so
Great
much.
job, everyone.
Bye-bye.
Hi, Anita.
Yep, hi.
Yes, if you want to leave the breakout room, you could just click on the blue button, leave room, and it brings you to the main session. All right?
Okay. Well,
It's over, right? This session is over, that's right?
Yeah, it's over.
Excellent. So great job. And thank you very much for the notice for the video. Nico prompted for you. So thank you very much.
Yeah, thank you for your help. Bye.
Excellent. See you on the other side. Hi, Mathilde.